Hello. Good evening, sir.
Yes, Dr. Devashish, welcome.
Good evening, sir.
Now we can see you clearly.
Devashish sir, good evening.
Good evening.
Ajit sir, good evening.
Good evening.
Rajesh, are you there?
Yes, sir.
Should we make a move and start?
Yes, sir. Arup, let's start our program. Okay. As per
Okay,
our
sir.
discussion, please start.
Can we
Okay,
go
sir.
live on audience link?
During the
Hello?
time, Dr. Dakko and Dr. Dadan Prasad will join.
Hello.
Can we go live on audience link?
Yeah.
Arup,
Hi.
We are live.
okay.
Okay.
Thank you.
Thank you.
Arup, please start.
Okay, sir. So, Doctor, good evening. On behalf of Alchem Laboratories, I am Arup Agarwal, the RM Bardhaman region. Welcome our eminent doctor who have joined us today as a panel discussion titled Views on Vildagliptin. At Alchem, it has always been endeavor to partner with the healthcare professionals, and we will continue to do so even in the challenging time also. To help us navigate through the meeting, we have with us Dr. Dipanjan Bandyopadhyay, who is our eminent doctor in Siliguri and HOD of North Bengal Medical College. Moderate for today's panel discussion. Dr. Dipanjan Bandyopadhyay, we would like to welcome you. Sir, welcome.
Yes, thank you.
Welcome, sir.
We take this opportunity to welcome Sir and Dr. Ajit Kumar Singh, Dr. Devashish Mondol, and Dr. Supratim Datta also. So, sir, I hand over the session to your hand and to you. Please, sir.
Good evening, everybody. I know despite very difficult times, we need to keep ourselves updated and we cannot afford to lose our edge over the happenings of medicine and clinical medicine. And today, I think Alchem is giving us an opportunity to review the positioning of gliptins vis-a-vis vildagliptin in our clinical practice. We have very important members of our profession as panelists, and I would like to begin the ball rolling by requesting Dr. Devashish Mondol, who happens to be a consultant physician from South Bengal. Sir, where would you like to position gliptins as a whole in your diabetic clinical practice? Dr. Mondol.
Okay. Good evening to everyone, and I am really thankful to the team of Alchem and my senior sets to give this opportunity. Actually, today I will be talking about DPP-4 inhibitor as a whole, particularly the molecule vildagliptin in elderly patient having diabetes mellitus. As we all know, as a junior physician, as far as I know, in every diabetic patient, we should start with metformin first. But nowadays, it has been seen that sometimes we can start with combination therapy. But before giving any combination therapy to a patient having diabetes for long duration, particularly in elderly patient, we should consider some fact, giving some new drug to metformin. What are those facts before giving this on? First of all, the events of hypoglycemia. We often found that some patient may complaining of suddenly fall, followed by head injury, convulsion, without any notifying disability or disorientation. So that may a result of hypoglycemia. It may cause from either irregular drug or irregular diet habit or direct effect of drugs. So we should keep in mind that in elderly patient, whatever we give the drug, that should not be do any type of hypoglycemia in any condition as much as possible. So in this regard, the molecule vildagliptin is very much safe, particularly for elderly patients who are very prone to develop hypoglycemia during the night times. Because once the hypoglycemic episode attack that patient may fall, head injury, convulsion, which may lead to unable to do the daily minimum physical activities to those type of patients. It may also cause the cognitive impairments, permanent brain damage. So always we should try to give some those type of drugs or molecule or groups of drugs in addition to metformin, which does not usually cause any type of hypoglycemia. So in this point of view, I think as far as I know, the group DPP-4 inhibitor, all molecule usually does not cause so much hypoglycemia. So for elderly or aged patient, apart from metformin with full tolerable dose, followed by we can add this molecule. I mean DPP-4 inhibitor or Globilda, which already the company bought. Next, apart from hypoglycemic episode, if we keep this concern that weight is an issue. If a patient comes to you with overweight, always we should try to give those drugs which usually causes weight reduction. But if the patient does have very much normal BMI or very much normal weight, then we can give any type of drug which usually does not affect the weight, either gain or loss, whatever it is. So if a patient comes to your clinics or if a patient comes to me without any issue of weight, then we can give any drugs. But in this regards also, the vildagliptin molecule is very much safe as it has the neutral effect on weight. So if a patient does not have any issue with the weight, then we can give him or add him the drug vildagliptin along with metformin. So we should keep in mind the weight also apart from that hypoglycemic episode. Followed by after that, it's always come with the duration of the disease course. What is that? Actually, if a aged patient comes to you with the long duration of diabetes, already this patient have a minimum functional beta cell reserve in isolates of pancreas. So we see that GLP-1 based therapy, which means the DPP-4 inhibitor molecule, are most efficacious drug to preserve the beta cell function of pancreas. So if a patient, whatever the age of that patient, comes to you after a long duration treating with metformin or others group of drug, then we can give him the molecule vildagliptin or DPP-4 inhibitor, as it is most useful to preserve that beta cell function. So that should be keep in mind before giving any drug add-on therapy apart from metformin in patient with diabetes, particularly with aged patient who usually come to you after a long duration suffering from diabetes mellitus. And if we consider the efficacy of the molecule DPP-4 inhibitor, all are more or less the same, but it's sometimes differ with the cost. So in our country, we should consider the cost benefit ratio before giving any drug to a diabetic patient. In this regard, I think with this molecule vildagliptin and others DPP-4 inhibitor like sitagliptin, teneligliptin, saxagliptin, prices does not differ too much. All are bit high, but molecule to molecule does not differ too much high. So anyone can be given. In this regard, you can give vildagliptin if you consider glycemic efficacy or compare glycemic efficacy among the different molecule. There are not so much different cost among the different molecule of DPP-5. And next come to addition and tolerability. Actually, among DPP-4 inhibitor, there are no tolerability issue. I still, as a junior consultant, I still did not get any patient who cannot tolerate the molecule vildagliptin or linagliptin, whatever you say, DPP-4 inhibitor. And one thing more, in a aged patient with diabetes, sometimes we often see patient may forget to take the drug in right time regularly. So in those kind of patient who does have already cognition impairment or physical inability or dependent to other to take the drug, in those type of patient, always we should give some kind of drug which usually once daily dose. In this regard, as a company already brought some molecule, particularly like vildagliptin, once daily dosing molecule. It's 100 mg per day we can give. It's have a long duration of action. It can given once daily, so that patient cannot forget to take the drug twice daily. As we give the drug more and more time, multiple times, it's very much possible to forget to take the drug regularly in regular time. So we should keep those type of drug in elderly patient who has longer duration with minimum daily dose, minimum times of daily dose, if it's possible to then once daily. So I would say before giving any oral anti-diabetic agent to a patient with diabetes mellitus or with as an elderly patient, we should consider this fact particularly: events of hypoglycemia, events of addition, events of tolerability, the duration of diabetes mellitus, cost-benefit ratio, apart from this glycemic efficacy. After keeping all this issue, we should prescribe the molecule after metformin or with metformin. So with metformin or after metformin, what are the benefit? This I think will be discussed later. But this is the fact: before giving any oral anti-diabetic agent, all these points should be keep in mind. And with that drug, which is minimum, those type of drugs should be given first. And one thing more, giving any type of drug, any group of drug to a diabetic patient, always the physician should focus on also adverse effect. The drug which has less adverse effects, less effect on physical health, that should be given first. In respect of vildagliptin, the major serious effect may cause hepatotoxicity as it's metabolized by liver, or sometimes pancreatitis may occur. Apart from this, some minor issue like nausea, headache, rash, this may occur. But as far as for last 1 year, as I still prescribing the vildagliptin along with metformin others molecule, I still did not get any such type of reports from any patient having pancreatitis or developed pancreatitis or jaundice or hepatotoxicity. Still, I would say that patient having severe liver disease, liver impairment, or advanced kidney disease, in those type of patient, it's always better to avoid this type of molecule as it also metabolized by liver. So it would also describe or discuss later in patient having chronic disease, which molecule should be given. So in a patient with diabetic molecule, this is overall the role of DPP-4 inhibitor molecule, I think nowadays.
I think that was a pretty exhaustive elaboration of the pros and cons of DPP-4. And thank you, Dr. Mondal.
Thank you, sir.
Is Dr. Dotto on board? Dr. Dotto?
Yes, sir.
Yes, good evening and welcome.
Just unmute your mic, sir. Dr. Dotto, please unmute your mic, sir.
Yes. So, good evening, Dr. Dotto.
Good evening.
We basically heard about the DPP-4s, and basically it was a recap of our own clinical experience. A very brief word. Do you really differentiate between one gliptin and the other when you select a gliptin for your patients?
Yes, sir. The main thing which I have to, one point I want to state out here is that since long in our clinical practice, we have seen the change of prescription habits also in physicians for the last 1 or 2 decades. Now, first, verified trial showed initially that if we initiate metformin alone or we add it with vildagliptin,
Yes.
then the rate of secondary failure is much more later rather than putting on a monotherapy.
Yes.
And this has been concluded in verified trial. Number one, sir.
Yes.
Number two, that priorly in the last few trials, like ACCORD trial, UKPDS, they dealt over years of patients who were uncontrolled, who were on uncontrolled diabetes, and medicines were given to have a strict control and CV endpoint. But all the medicines, Dulaglutide, Glyburide and all. So at the end, the rate of adverse events was not that low as was seen in ACCORD or advanced trial.
Yes.
We have the privilege of starting the patient on two molecules, gliptins and metformin. So we can be sure that we don't have to go to the second drug, depending on their BMI or not. This is
May-
my take.
May I just interrupt and add that the amount of database and amount of evidence base in favor of vildagliptin is also a motivator for us to use Vilda in our clinical practice,
Yes,
because
definitely.
we have other gliptins as options as well.
Yeah. Now, if the amount of data with vildagliptin is not right there for teneligliptin even, because it has just evolved over years. And I don't think, as per my opinion, teneligliptin doesn't have an adequate control like that of BD vildagliptin. And moreover, the incidence of hypoglycemia is almost to be said nil in case of vildagliptin.
Yes.
The tolerance of the patient will be one of the most important things. Second, I will also try to reduce the weight of the patient. Now, at times with vildagliptin and metformin plus metformin alone, there is a mild less reduction of weight in case of gliptins and metformin. But that has to be taken into account. So if I am to prefer, I will go with that molecule, which has a track record and has studies to show that it's performing. That's my premise.
Well taken. And I think it's time that we ask the nephrologist on the panel, Ajit.
Yes, sir.
We have all been, favoring linagliptin when it comes to a renally impaired patient. And we all remember the chart of dose reduction with all the gliptins.
Yes, sir.
So, as a diabetic, with a diabetic perspective, where would you place Vilda in your practice? Because not all diabetics are CKD.
Sir, good evening, everyone. Gliptins are one of the favorite anti-diabetic agents for the nephrologists. So in almost all the prescriptions, you will find a gliptin there. Metformin is obviously out in our prescription. Once the patient is with nephrologist, metformin is out. Very rarely we see patient coming with only proteinuria with normal renal function. So we don't use metformin. Now, CKD, as it advances, there are other drugs also like sulfonylureas. They are usually no role. So now we are left with insulin and then gliptins. And then SGLT2 inhibitors if we are fortunate enough to get the patients with GFR more than 45 something. Now gliptins, as per my personal experience and otherwise also, almost all the gliptins are being used by nephrologists. Say sitagliptin, vildagliptin, linagliptin, and then newer gliptins also. It's all about the simple knowledge of the dose modification. If we know like sitagliptin, for ESRD 25 milligram is as good as linap 5 and then vilda 50. So all the gliptins are being used. No one is superior to other, as if we are modifying the dose adequately. That is important. And I don't think there is very good data available or head-to-head trials available to prove the superiority of one gliptin
over the other
in CKD. Yeah, dose modification is essential. Vilda 50 for Vilda, particularly since the discussion is on Vilda. So we remember 50-50. So like GFR less than 50, dose is
Dose
50 BD. GFR more than 50, dose can be 50 BD or 100 OD as explained by the colleague. The advantage of 50 OD Vilda in lower GFR is that if you see the pharmacokinetics, pharmacodynamics, the action is prolonged and the effect is somehow similar to 100 milligram of vildagliptin. So the cost of therapy becomes half. That is one clear-cut advantage. So we use Vilda 50 even in the ESRD patient, even in the dialysis patients as well. Obviously, with all the gliptins, the risk of hypoglycemia is less. Almost all the gliptins have similar hypoglycemic profile, I mean low hypoglycemia, because of the inherited DPP-4 inhibition, the inherited mechanism of action itself.
Yes.
Very less with gliptin and metformin also in the verified trial that showed.
Yes.
Was at 1.3%, I think, like that. The least amount.
Verified trial, yeah, clearly established the fact that we can go to the combination therapy in the very beginning of the disease course itself, so as to be like, have a very good control of sugar, so as to prevent the long-term complications, all the complications, including nephropathy.
Yes, so I think the message from Dr. Singh is that none of the gliptins are superior and Vilda is a very valid option even in the face of significant renal impairment.
Right.
So I think that is a very encouraging piece of data. Arup, is Dr. Prasad on the panel, or is he yet to log in?
No, sir.
Dr. Prasad?
Dr. Prasad will not join, sir.
Then we might go to any of our panelists ask. We have the combination of linagliptin with SGLT2 inhibitors in the market. How do you foresee a combination of vildagliptin with an SGLT2 inhibitor? Would that be clinically optimum? Would that be clinically useful to us? Dr. Mondal?
Sir, I still did not have that much of data with this type of combination, and I still did not found that type of molecule or prescribe that type of molecule. So, sir, I'm very much sorry to say about the possibility of that type of molecule benefit.
Yes, I think we can reframe the question and maybe go to Dr. Datta once again.
Yes, sir.
We were talking of combinations and verify and etc. So how would you position the combination of a vildagliptin with an SGLT2 inhibitors?
Yes, sir. Now some molecules have come up in recent months. This gliptins and remogliflozin. This way in the market, few months back it has come. Now, I have personally used it in patients who are having a gross BMI initially presenting with a history of initial diabetes of around 6 months uncontrolled. Now, my primary target was to reduce the surface area of the person so that so as to see what does reduction of surface area, that is in body weight of the person, how good glycemic control we can achieve. Now, obviously, it was not initiated just in a monotherapy basis. It was given the combination of SGLT2 and DPP-4 with metformin. Knowing that the patient is a very obese patient, and he had comorbidities of hypertension with dyslipidemia, everything. For the last 1 year, I have seen personally in my practice that after the weight reduction of the patient, which is definitely a boon for SGLT2 with metformin, addition of DPP-4 or SGLT2, there was a good reduction in blood pressure control also after reduction of weight and diabetic parameters also. So in case of obese diabetic patient, the primary, I think the mechanism of treatment also has changed over a few years. Priorly, we were told that start with a single drug, then add another drug. Put on 2 drugs, then on 3 drugs. So that takes a lot of time, and by the time the patient also has an inertia of treatment, our sugar comes in. That was the main thought process. Now, what I have seen that if you can make the patient understand that body weight has a major impact on your control of diabetes, and this can be dealt with, then many of them obviously can justify the surgery. So personally, I have seen good results with these combinations.
Again, very clear.
My question is from the very beginning, if a patient comes to me, first
Yeah.
diagnosed with having symptoms of diabetes mellitus and diagnosed with diabetes, then can we give this combination from the very beginning without metformin, without initiation of metformin?
We can
Uh,
obviously.
Yes, Dr. Dotto.
No, what I have seen, sir, I have used it extremely in my practice. So suppose a patient comes with a blood sugar of, suppose it is PP is in the range of 180 to 200, fasting is in the range of 120 to 140, HbA1c is just at 6.9 or 7, below 7. Then obviously if he is obese, we can start only with DPP4 and SGLT2. Now, both has two separate mechanisms of actions. The loss of huge amount of glucose in the urine through SGLT2 definitely helps in reduction of the weight. And we should also remember that it is cardioprotective as well.
Yes.
Renoprotective.
And on the other hand, we are not stimulating the pancreas. So a bit of DPP4 can also act in its own territory. The results are extremely good. So if you also give HbA1c below 7, not that severe hyperglycemia in an obese patient, we can definitely put it.
I think what we are looking at basically is a paradigm shift in the recommendations or guidelines that we come up in the future. Because as of now, we, as you pointed out, we need to begin with metformin. But I think that dicta is going to change in future and possibly in the very near future. And we are already getting patients who are doing well with a non-metformin regimen. What is important is that metformin in combination with vildagliptin is a very valid initial therapy. I think many of us are using it day in and day out. And most interestingly, the sulfonylureas have taken a backseat because sulfonylureas, we are more bothered about the negatives of sulfonylureas. I did not imagine a prescription without sulfonylureas maybe 10 years back or 15 years back. But today, I think 50% of my diabetic prescriptions do not have a sulfonylurea. And wind up, I would just like to ask my panelists, where would you position vildagliptin or gliptin in combination with insulin? Because there would be patients who would be requiring insulin at the end of the day. We have majority of them who don't like to take 2 or 3 shots in a day. So we try to, have insulin once a day. Even premix insulin, we start with once a day. And where would you put the gliptins in association or in combination with insulin?
I will prefer it when I'm shifting a patient to a basal insulin once a night or once a day. Then for the PP control, because with basal insulin, it is obvious that we will be seeing first to fix the fasting blood sugar.
Yes.
But other thing is that it will take some time to control the fasting blood sugar.
Yes.
We cannot let the PP also get higher fast without checking the PP blood sugar.
Okay.
In this context, metformin and DPP4 definitely has a role in combination with basal insulin.
And now we know that the Indian HbA1c is more dependent on the PP than on the fasting. Yes, Ajit, your take.
Sir, my subset of patients, particularly dialysis patients, they are unique in some of the features. One is like some say 20% of the patients, they actually don't require any diabetic therapy altogether. they develop ESRD, and then the sugar is almost normal and diabetes is apparently cured. Now, the majority of the patients are actually requiring lower anti-diabetic drugs. So what I do, I put them on a basal insulin. Premix is out in my dialysis patients. I have seen severe hypoglycemia there. So basal insulin, preferably during daytime. I usually give 10 a.m. or 11 a.m., not at night, plus gliptin at night. So vildagliptin with
gliptin.
plus 1 gliptin, yeah. So a gliptin plus a basal insulin. So my dialysis patients, they do well on this combination.
Wonderful, wonderful. Dr. Mondal, your comments.
Yeah.
We're almost at the end of the session.
So, sir, I think nowadays we can give the DPP-4 inhibitor molecule from the very beginning, maybe along with metformin or along with SGLT2 inhibitor, and we may follow the patient with the lab report. If it is good, then we may continue this drug. And as you said, sir, if it is not well controlled, then we may add the basal insulin. As far as I don't have this type of experience with insulin and basal insulin and oral anti-diabetic agent, I only either give oral anti-diabetics or only in human regular insulin. But as I just got informed, this type of combination may be given for smooth control. So along with insulin, last time when the sugar is very much high, not controlled with only oral drugs, then we may put on gliptins along with basal insulin. That's my message.
I think whatever we have discussed over the past 40 minutes or so basically gives a very broad spectrum of usage of the gliptins.
Yeah.
So we can use it head on at the start. We can use it in isolation or in combination. We can use it in patients with renal impairment and significant renal impairment. And most importantly, we can also use it in combination with insulin. So that gives really a large playing field for these group of molecules. Coming and focusing on Gluvilda and vildagliptin, which is the center of our attraction this evening, vildagliptin has become or has evolved into one of the most important gliptins in our clinical practice. Partially because of the large evidence base, but I think also because of the large personal experience that we have all gathered on this molecule. So once you have the clinical experience and the clinical confidence of prescribing a molecule, that becomes one of your preferred agents in your armamentarium. Is there anything more to add from the panelists before we call it a day? If there be none, I think we can thank Alkem Laboratories once again, and we must wish ourselves and our families all the best, because we are passing through one of the most tough times that we could ever have imagined. And we all hope that we get out of this pandemic, we get out of this epidemic, and we actually have on-site real CMEs in future. Over to Rajesh.
Thank you, sir. Thank you very much. It is really, it was a very good discussion, sir. Sir, my one question direct to Dr. Deepanjan Bandyopadhyay. Sir, as you are aware, recently we have launched vildagliptin OD form, 100 milligram sustained release form, sir. And sir, we have two documents to support this OD formulation for BD dose of innovator brand. Like sir, bioequivalence study shows 50 milligram BD, that is innovator brand, is bioequivalent as per with the 100 milligram of Gluvilda. This is number one, 86% score, that is for innovator brand, and for 100 milligram Gluvilda, that is 84.5%. So almost at par BD and 50 milligram BD or 100. Obviously, the price is the matter for Indian patients, sir, and our price is just 10 rupees. So patient will be benefited with this Gluvilda OD. Number one, sir. Number two, sir, obviously the pill burden, because diabetic patients who are suffering from diabetic hypertension along with this CKD, maybe sir patient taking 10 to 15 medicine in a day. So at least for Gluvilda OD, if we suggest Gluvilda OD instead of BD, sir, maybe pill burden will reduce particular for those patients. The number
I-
two, sir.
Rajesh, I think we have already touched upon this, that
Yes.
a OD formulation is any day better than a BD formulation. One of the panelists mentioned this very clearly. The only point again I'll reiterate is that if you have a 100 milligram extended release formulation,
Yes.
give us a little time, let us have some clinical experience ourselves, and I'm sure we will be using it, provided it serves our purpose. So on behalf of the physicians, I would say that we all need our own personal experience to have that level of confidence in a molecule or a formulation.
Absolutely, absolutely, absolutely. Sir. So,
Thank you so much.
Thank you so much, sir. Arup,
And
over to you.
what I would like to add here
Yes, sir.
is-
Yes, sir.
is that in combination which you have brought in market or the other companies have come up with, 50 milligram of vildagliptin with 500 metformin or 1000 metformin. Some patients are grossly metformin intolerant.
Yes.
As in your case, with your molecule, the problem is that if it is going and being released immediately in the stomach, maximum of the patients come with gastroesophageal reflux, dyspepsia, this and that. Now, that point has to be taken on, I think, from your company's point of view, how you handle it. Because if that is the reason, because if you have to give it BDAC, then the problem arises out there in the patients who are susceptible to side effects of metformin, if not in a sustained release formulation.
I would just like to pick up from where you left. That metformin intolerance, I think, is a different ballgame. And if it is metformin intolerance, then number one, we should avoid metformin. As you very rightly pointed out, we can use metformin post-meal, because post-meal metformin obviates side effects to a large degree. But then we also have Gluvilda without metformin. So we can use the plain Gluvilda molecule or plain Gluvilda brand if you're thinking of metformin intolerance in your patients. So I think that addresses the issue at least to some extent.
Yeah, that's okay, sir. Then we have to separate both the molecules and then give.
Yes, yes. Rajesh, I think it's time we wind up. I think we
Yes,
all
sir. Arup,
need to go to the hospital.
Thank you,
Arup,
sir.
over to you, please.
Thank you, sir. We take this opportunity to thank Dr. Deepanjan Bandyopadhyay as a moderator, the panel discussion, all the panelists, Dr. Singh, Dr. Mondol, and Dr. Datto for views on vildagliptin for their clinical practices. We would also thank to Dr. Joannas, very took their views very clearly and help us to their colleagues to take their decisions on vildagliptin. So thank you all. And we at Alkem Laboratories, we will continue the serve to the doctor and patient by making products available, especially our chronic brands and Gluvilda M. Thank you, sir.
Thank you very much, sir. Ajit sir, thank you very much. We'll meet soon. Devak sir, thank you very much for your presence, and it was really nice discussion. And obviously, we being a industry person, at least gather some knowledge out of this discussion. And definitely, sir, this information will pass on this information to our GP across countries, sir. Thank you very much, sir. Good night, sir.
Thank you.
Thank
Thank you.
you.
Good night.
Good night, sir.
Thank you,
Good
sir.
night.
Thank you.
Good
Good
night.
night.